All right, welcome back to the deep dive. Today feels different. The studio lights are a bit brighter, the air conditioning is humming a bit louder, and I've got a stack of textbooks in front of me that could double as structural support for a small building.
Yeah, I can see that.
We are shifting gears today. We are going into full-on exam simulation mode.
That's right. And if you're listening to this, I'm guessing your pulse is already a little elevated. You are likely preparing for the MD anesthesiology exams, specifically the Gujarat University format.
That's the one?
So for the next hour, I want you to forget that I'm a podcast guest. I am your senior faculty. I am the professor sitting across the table from you in the Viva, holding your mark sheet.
I can feel the pressure already. Okay, Professor. I'm the candidate. I'm the learner. I've got Miller's anesthesia, Morgan and McCall, Guyton and Hall for the physiology, and intensive care manual all up in here.
Good.
My goal is to survive this session without getting kicked out of the program.
Good. The topic on the table is one that strikes fear into the heart of every postgraduate student. We are discussing hypoglycemia, hyperglycemia, and Kernicterus in pediatric patients.
It's a terrifying topic because it just feels like a minefield. The margin for error in a neonate is practically zero, and the textbooks don't always seem to agree on the numbers.
It should terrify you. That fear is the only thing that keeps your patients safe.
Yeah.
The reason we examiners obsess over this topic is that a neonate is not just a small adult.
Right.
It is a completely different biological operating system. If you treat a 3-kilogram neonate with the same metabolic logic you use for a 70-kilogram adult, you will cause permanent brain damage.
Understood.
Yeah.
So the mission is to master this for the theory paper, getting those 10 to 15 mark answers structured correctly, but mostly to navigate the Viva traps you're going to set for me.
Exactly. We have a lot of ground to cover. We're going to break this down into specific parts, starting with the introduction and exam framing, then moving through hypoglycemia, hyperglycemia, Kernicterus, and finally how to integrate this all into a passing exam answer.
Let's do it.
Let's start with Part A. Why is glucose homeostasis such a cornerstone of the pediatric anesthesia curriculum?
Well, looking at Miller, it starts with the metabolic engine. The fundamental difference is the rate at which these kids burn fuel.
Quantify that for me. High metabolic rate is a generic answer. It won't get you full marks. Give me the numbers.
Okay, a neonate's glucose requirement is roughly 5 to 6 milligrams per kilogram per minute.
And an adult, for comparison.
If I compare that to an adult who needs maybe 1.5 to 2 milliglycogen, the neonate is burning fuel at nearly triple the rate relative to their body weight.
Correct. And where is all that fuel going?
Right.
Which organ is the primary consumer?
The brain. It's all about the brain. Miller calls the brain an obligate glucose user.
What does that actually mean, obligate user?
It means it's incredibly picky. This is a point Guyton makes very clearly. The brain, in the acute phase, cannot easily switch to alternate fuels.
Right. A muscle can burn fatty acids, it can burn protein, but the brain.
The brain wants glucose. And the key thing is, and this is a common MIVA question, does it need insulin to get that glucose inside the neurons?
And the answer?
No. That's the crucial distinction. Neuronal glucose uptake is insulin independent.
Okay, so it can get the glucose easily, but what's the catch?
The catch is that the brain has almost no glycogen storage of its own. It's entirely dependent on the continuous delivery of glucose from the blood.
Exactly. It's living paycheck to paycheck, energy-wise.
Yeah.
It doesn't have a pantry.
Not at all.
So if the blood supply stops, or if the concentration in the blood drops, you don't have a buffer of 20 minutes like you might in muscle. You have seconds to minutes before function fails.
That leads to the concept of immediate metabolic peril. In an adult, if they go hypoglycemic, they have reserves.
So.
In a neonate, interruption of substrate equals injury.
Yes.
But it's not just about the fuel running out, is it? It's also about the structure of the brain itself.
You're referring to the vulnerability of the neonatal brain. Why is it so fragile?
Well, the blood-brain barrier, the BBB, it's immature. Both Miller and the Doctor podcast notes really emphasize this. The tight junctions between the endothelial cells. They aren't actually that tight yet.
They're leaky.
Exactly. It's permeable. This lets things in that normally wouldn't pass, like bilirubin, which I'm sure we'll get to, but it also makes the brain incredibly sensitive to osmolar shifts.
Explain the osmolar risk. Why is that so important for us?
Because glucose is an osmol. It exerts osmotic pressure. So if I rapidly change the sugar concentration in the blood, water will rush across that leaky BBB to balance it out.
What's the consequence of that?
If I drop the sugar too fast or spike it too high, I cause rapid fluid shifts. That can lead to cerebral edema or, conversely, shrinking of the brain, which can tear the bridging veins. It's a disaster either way.
Precisely. So your role as an anesthesiologist isn't just keeping them asleep. Miller puts it beautifully. The goal is to maintain or improve existing homeostasis.
I like that.
Because once collapse occurs in a neonate, once that energy supply fails, resuscitation is a nightmare.
It's not like fixing a flat tire. It's like trying to rebuild the engine while the car's doing 100 miles an hour.
That's a vivid image and one you should keep in mind. Now, before we dive into the specific pathologies, let's frame this for the exam. How does this topic usually appear in the Gujarat University papers?
Okay. It's often a short note, something like neonatal glucose regulation or just Kernicterus.
Right.
Sometimes it's a full 15 marker on anesthetic management of the neonate where this becomes a major subheading. But honestly, I'm most terrified of the Viva questions.
The Viva is where they test your safety, not just your knowledge. They will ask practical questions. Doctor, how do you manage intraoperative fluids? Do you give glucose or not?
And the OSCE?
And for the OSCE, be ready to calculate a bolus. If I hand you a scenario with a crashing 3-kilogram neonate and you hesitate on the math, you fail. Simple as that.
Okay, let's get into the weeds then. Part B, hypoglycemia. This feels like the most immediate threat to life.
It is. Hypoglycemia kills quickly and it kills the brain first. So let's define it. In the exam, if I look at you over my glasses and ask, Doctor, what is the definition of hypoglycemia in a neonate? What do you say?
This is tricky because, like I said, Morgan says one thing and Miller implies another. Strictly speaking, for a preterm or term neonate in the first 72 hours of life, the textbook value is often cited as less than 30 milli-GDL.
Okay, so you're in the OT, you check a gas, and your neonate's sugar is 31 milli-GDL. You happy?
Absolutely not. No way. That feels way too close to the edge.
Good instinct. And that is exactly how you answer the examiner. You show clinical judgment.
So you should say that.
You say, sir, while some older physiology texts cite 30 milli-GDL as the lower limit for the first 3 days, clinically and for the purpose of safety, most modern anesthesiologists consider anything less than 40 milli-GDL, or even 45 milli-GDL as requiring intervention.
So I acknowledge the book value, but I prioritize clinical safety.
Always. In an exam, safety trumps strict textbook adherence every time. If you accept a low value without qualifying it, you look dangerous.
That makes sense. What about for an older child, a 6-year-old, for example?
What do you think?
Well, the bar is higher. We treat them more like adults, so anything less than 60 milli-GDL is definitely a red flag.
Good.
And Harrison talks about Whipple's triad here. Symptoms, low glucose, and relief with glucose.
Well, what's the problem with that in our setting?
But Whipple's triad seems, well, kind of useless to me in the operating theater.
Why?
Because I've anesthetized the patient. I can't exactly ask an intubated 6-month-old if they are feeling dizzy or hungry. The symptoms are completely masked.
Exactly. This is an examiner-oriented explanation. You need to explicitly state, Whipple's triad is the gold standard for awake patients, but under anesthesia, the signs and symptoms are masked, so we must rely on biochemical monitoring. It shows you're thinking practically.
Got it. Okay, now let's talk causes. This is an exam favorite for sure. Why do these kids go low?
It comes up every year. How do you categorize them?
I organize this into 3 buckets in my head. Bucket 1, the fuel tank is just too small.
Go on, explain that.
Prematurity and low birth weight, or LBW. Guyton explains that the liver is functionally inadequate at birth. The enzymatic machinery for gluconeogenesis, the ability to make new glucose from protein or fat, just isn't fully online yet.
And what about the existing stores?
That's the other half of it. Miller notes that preemies have reduced glycogen stores. They literally haven't had enough time in the womb, specifically the 3rd trimester, to build up their pantry. So they run out of fuel almost immediately.
Corrupt. A very vulnerable group. Bucket 2.
The insulin trap. This is the classic one. The infant of a diabetic mother, the IDM. I know examiners love asking about the mechanism here.
Walk me through it, step by step, as if you're explaining it in a Viva.
Okay, so the mother has uncontrolled hyperglycemia. That high level of glucose crosses the placenta freely. So the fetus is basically swimming in a high-sugar environment for months.
Right. And what does the fetal body do in response?
To cope with this massive sugar load, the fetal pancreas undergoes hyperplasia, it gets bigger, it gets stronger, and it pumps out huge amounts of insulin. You get fetal hyperinsulinemia.
Okay, so the baby is born with a superpancreas. Then what happens?
Then birth happens. The umbilical cord is clamped, the maternal sugar supply stops instantly, but the baby's pancreas doesn't know the war is over. It's still pumping out insulin like crazy.
And the result?
A massive crash. High insulin, 0 intake, the glucose plummets. That's your profound hypoglycemia in the first few hours of life.
That is a very high-yield Viva point. If you have an IDM baby on your list, you need to be checking sugar before you even induce anesthesia.
Absolutely.
Okay. Bucket 3.
High demand. Sepsis is the big one because the metabolic demand just skyrockets. The body's burning through everything it has. And then there's prolonged fasting.
Let's talk about fasting. This has changed, hasn't it, in our practice?
Drastically.
Yeah.
We used to starve kids, just like adults. NTO after midnight. Morgan makes it really clear that neonates cannot tolerate starvation like that.
So what are the modern guidelines?
Now, the modern guidelines, and Miller supports this, allow clear fluids up to 1 or 2 hours pre-op. It's a huge change.
We do that specifically to mitigate this hypoglycemia risk. It's a safety measure. Now let's put it all together. Imagine you are in the OT. You have a 4-month-old on the table. You've induced anesthesia. How do you know if their sugar has dropped to 30?
That's the scary part. In a awake child, O's intensive care says you'd see jitteriness, a weak cry, maybe sweating or tachycardia,
Yeah.
the adrenergic signs.
But under anesthesia.
You've blunted the sympathetic response.
Exactly.
With sevoflurane and maybe some fentanyl on board, I won't see the jitters. I might not even see the tachycardia if I have them deep enough. The classic signs are gone.
So what might be the only sign you see? The first clue that something is wrong?
Often it's intractable hypotension. You're giving fluids, you're lightening the gas, and the blood pressure just won't come up.
What else?
Miller also says bradycardia is a late, really ominous sign. Or, honestly, the most common presentation might be simply failure to wake up at the end of the surgery.
Which is a disaster. If you wait until the end of the case to realize the brain was starving for 2 hours, the damage is already done.
That's why the mantra is monitor, monitor, monitor. You have to check.
Let's dig into the why, though. Why does the brain die without glucose? I want the pathophysiology. This is exam gold. What's the mechanism?
It's all about ATP. It comes down to energy. Morgan states brain glucose consumption is about 5 milligrams per 100 grams of tissue per minute. If the substrate fails, ATP production just stops.
And without ATP, what's the first domino to fall?
The sodium-potassium pump fails. This is the pump that keeps the cell environment stable, pumping sodium out, potassium in.
And when it stops?
If it stops, sodium rushes into the cell, water follows the sodium, so the cell swells up.
And then it gets worse.
Then you get excitotoxicity. The membrane depolarizes, which causes a massive release of glutamate. Calcium then floods into the cell.
And calcium is the executioner.
Right. The calcium activates proteases and lipases that literally digest the cell from the inside out. It's neuronal necrosis. Game over for that cell.
Perfect. That is the answer that gets you the distinction. You've explained the entire cascade. Now, management. This is the very high yield section.
The practical stuff.
Exactly. Scenario. You check the sugar in your 3-kilogram neonate. The glucometer flashes 25 milli-GDL. What do? What's your first action?
I treat the emergency immediately. I need to give a bolus.
What do you give? Be specific.
O's manual is my Bible here. It's very clear. The standard is 2 millimels per kilogram of 10% dextrose.
Stop. Why 10%? Adults in an emergency sometimes get 50% dextrose. Why not give a little shot at D50? Get the sugar up fast.
No, because D50 is incredibly hyperosmolar. If I push D50 into a neonate's tiny vein, I risk 2 major things.
Tell me.
1, thrombophlebitis, it just burns the vein. But 2, and much more importantly, that sudden hyperosmolar load can suck water out of the brain so fast it can cause an intraventricular hemorrhage or IVH.
Excellent. Never, ever say D50 for a neonate. It's an automatic fail in any exam. So, back to the math. Our 3-kilogram baby.
Okay, 3 kilogram times 2 milligram per kilogram. It's a 6 millimole bolus of D10.
Good. Now, some texts, like Morgan, suggest a range of 0.5 to 1 neurogram per kilogram, which works out to a much higher volume, maybe 5 to 10 millirole kilogram. Why do I prefer the O's 2 milliliter kilogram rule for the initial bolus?
It's to avoid overshoot.
Exactly. Explain that.
If I give too much sugar all at once, I cause hyperglycemia. That huge spike triggers the pancreas to dump insulin, and 30 minutes later, the baby crashes again into rebound hypoglycemia. You're just creating a glucose roller coaster.
Exactly. Start small, give the 2-LO-kg, recheck in 15 minutes. Then what? The bolus won't last forever.
Then I need to start a maintenance infusion. I need to match that normal hepatic glucose output, which is roughly 5-6 millikilmin. Practically, this usually means running a D10 solution at maintenance rates.
And monitoring. How often do you check?
At least hourly. Miller says don't guess. If they are high risk, a preemie, an IDM, a baby on TPN, you check every hour, period.
Perfect. You stabilize the low sugar, you save the brain. Now let's swing the pendulum to the other side. Part C, hyperglycemia.
This feels like the area where our specialty has shifted the most in the last decade or so.
It has, completely. When I was training, we gave dextrose to everyone because we were so terrified of hypoglycemia. Now, we are just as terrified of hyperglycemia. Why?
Let's define it first for the exam. Generally, we're talking about a glucose greater than 150 milli-GDL, maybe up to 200 milli-GDL.
There's some variation.
Yeah. Miller notes that 126 milli-GDL is the diabetic diagnostic cutoff, but in a surgical stress response, we tolerate a bit more, maybe up to 180 before we get too worried.
Right. Surgery itself, the stress releases catecholamines, cortisol, glucagon. Glycogenolysis happens, sugar goes up naturally, we expect that.
But there's also iatrogenic hyperglycemia, the glucose trap. This is what we cause.
What do you mean by that?
Overzealous administration of D-containing fluids during routine surgery, giving sugar to kids who don't need it.
Now, here is the exam gold for hyperglycemia. Why is it bad? Why do we care if a kid's sugar is 250 during surgery? It's not like they're diabetic.
It's the anaerobic metabolism problem. This is a crucial concept for exams. Miller explains that if there is any ischemia, any lack of oxygen to the brain, hyperglycemia makes the neurological injury much, much worse.
Explain the mechanism. This is key.
Okay, so under ischemic conditions, the cells can't use oxygen, so they switch to anaerobic metabolism. If you have a flood of glucose available as fuel, the cells just churn through it via anaerobic glycolysis.
And what's the byproduct of anaerobic glycolysis?
Lactic acid, a huge amount of lactic acid.
And what does lactic acid do inside a neuron?
It causes profound cellular acidosis. It literally cooks the neuron from the inside out. It denatures proteins, destroys enzyme function, and leads to neuronal death.
Exactly. This is the key phrase for the exam. Hyperglycemia provides excess substrate for anaerobic glycolysis, leading to intracellular lactic acidosis.
Yeah.
It turns a potentially recoverable ischemic injury into permanent brain damage.
That's a powerful image. It's not just high sugar, it's like pouring acid fuel on a fire.
A perfect analogy. But there are other consequences too, right? What about osmotic diuresis?
Right. Harrison and Morgan both explain that if glucose goes above the renal threshold, which is roughly 180 mg/dL, it starts to spill into the urine.
But what follows the glucose?
Water. Glucose is an osmoly, so it drags water and electrolytes with it, causing a massive diuresis.
Leading to?
Dehydration. And usually hyponatremia. Harrison sometimes calls it pseudohyponatremia because of the osmotic shift, but the diuresis causes a real electrolyte loss too.
And in the very fragile preterm brain, what's the specific risk there?
Kaushik Jathanaf specifically mentions the increased risk of intraventricular hemorrhage, or IVH, in very low birth weight infants. It's due to those hyperosmolar shifts. The rapid changes in osmolarity cause those fragile germinal matrix vessels to stretch and pop.
Precisely. So, knowing all this, how do we manage fluids intraoperatively? This is the paradigm shift.
We move away from routine dextrose for everyone. The standard of care now, according to Miller, is to use isotonic balanced salt solutions, things like Plasmolite or Ringer's lactate.
Wait a minute. I hear a junior resident in the back asking, but sir, if we don't give sugar, won't they all go hypoglycemic?
That's the old fear. And the answer is no, not healthy children. Healthy children over a certain age have enough glycogen stores for a standard-length surgery.
So what's the greater risk?
For them, the risk of iatrogenic hyperglycemia from giving D-Fi routinely is actually higher and potentially more dangerous than the risk of them spontaneously becoming hypoglycemic.
But there are exceptions. Who must get some background sugar?
The high-risk groups we've already mentioned, the preemies, the infants of diabetic mothers, neonates, and cases that are going to be very long.
And how do we do that safely?
For them, we might use a lower concentration, like a 1% or 2.5% dextrose solution as our maintenance fluid. Or, even better, run a separate syringe pump of D10 at a very low rate alongside the main isotonic fluids.
Excellent. The two-bag technique, or the syringe pump method, is very sophisticated, and examiners love to hear that. It shows you can titrate one without affecting the other.
It gives you precise control.
What's one fluid you should never use for volume replacement?
Oh, this is a big one. Miller warns, do not use D5W as a replacement fluid for blood loss or third space loss.
Why not?
Because once the dextrose is metabolized by the cells, which happens almost instantly, D5W is just free water. It's incredibly hypotonic. You'll cause massive hyponatremia and cerebral edema in seconds. It's extremely dangerous.
And pass that section with flying colors. Now let's move to our third major topic. Part D, Kernicterus. This seems like a purely pediatric topic, but why is it so critical in the anesthesia exam?
because we are the ones giving the drugs that can cause it, and we are also
Yeah.
managing the physiology that can either prevent it or make it worse.
Correct. So let's define it for the examiner. What is Kernicterus?
Kernicterus is simply bilirubin-induced brain dysfunction. The word kern refers to the nucleus, specifically the basal ganglia, which gets stained yellow. It happens when there is severe unconjugated hyperbilirubinemia.
You highlighted the key word there, unconjugated. Why does that specific form of bilirubin matter so much?
Because conjugated bilirubin is water-soluble, it can be processed by the liver and excreted in the bile. It's relatively safe. But unconjugated bilirubin is lipid-soluble. It loves fat.
And what's the brain made of?
The brain is basically a big lump of fat, so it's a prime target.
Exactly. But usually the blood-brain barrier keeps it out, even if it is lipid-soluble.
Right, but as we established in the introduction, the neonatal BBB is immature and leaky. Miller and Dr. Podcast both emphasize this. So if the levels of unconjugated bilirubin get too high, or if the BBB is damaged by something like hypoxia or acidosis, the bilirubin just crosses right over.
There's another safety mechanism in the blood, though. Albumin. What's its role?
A huge role. Unconjugated bilirubin travels in the blood bound to albumin. I think of albumin like a taxi. As long as the bilirubin is bound to a seat in the taxi, it's too big and bulky to cross the BBB.
So the danger arises when?
The danger arises when you have too much bilirubin and you saturate all the albumin binding sites. The taxis are all full. OR, and this is the big anesthesia trap when you give a drug that kicks the bilirubin out of its seat.
Bingo. This is the classic Viva trap. Doctor, which drugs displace bilirubin from albumin? Name them.
Sulfonamides are the classic answer from all the textbooks.
Yeah.
Ceftriaxone is another huge one we use commonly. And then Harrison and Miller also mention salicylates and, importantly for us, rapid high-dose furosemide.
So if you have a jaundiced neonate for surgery and they develop an infection, do you give ceftriaxone?
No, you avoid it. You choose a different antibiotic. You don't want to be the one who bumps the bilirubin off the albumin and sends it straight into that baby's basal ganglia.
Good. What does kernicterus look like clinically? If you're doing a pre-op check on a baby in the NICU, what are the signs?
Well, the early signs are quite nonspecific. Lethargy, poor feeding, maybe a loss of the Moro reflex. It can be subtle.
But then it progresses.
Then it gets scary. The intermediate signs are epistenos, that horrible arching of the back, and a very high-pitched, inconsolable cry, seizures.
And if it's not treated, what are the late permanent sequelae?
This is the tragedy of it. You get chorioethatoid cerebral palsy because the basal ganglia are permanently damaged, and sensorineural hearing loss because it also damages the cochlear nuclei in the brainstem.
Excellent. So management. Obviously, prevention is key. Phototherapy helps by photoisomerizing the bilirubin into a water-soluble form that can be excreted. But if it's critical, we do an exchange transfusion.
And an exchange transfusion has massive anesthetic implications.
Tell me about them. What are you worried about during that procedure?
You swapping out the baby's entire blood volume. So first, I'm worried about hypocalcemia from the citrate toxicity in the donor blood. The citrate chelates calcium.
What else?
I'm worried about hypoglycemia. The preservative in stored blood is high in glucose, which triggers a big insulin release. Then you stop the transfusion and the baby's blood sugar crashes. And finally, hypothermia is a huge risk, obviously.
Perfect. You're thinking like an anesthesiologist. Okay, let's tie this all together. Part E, the big picture. You mentioned a safe brain strategy. Summarize the anesthesiologist's role in the NICU and the OT regarding these three conditions.
It all comes down to maintaining the normals, homeostasis.
Break it down for them.
Okay. Number 1, maintain normoglycemia. Avoid the extremes. Both hypo and hyper are bad for the brain.
2.
Maintain normothermia, because hypothermia worsens acidosis, and acidosis increases the risk of kernicterus. Maintain normocapnia. Acidosis displaces bilirubin from albumin, while severe alkalosis constricts cerebral blood flow. So you want to be right in the middle.
And the last one.
Oxygenation. You have to maintain it. Hypoxia opens up the BBB even further, making all of these problems worse.
It's a balancing act. You are the physiological guardian of that fragile brain.
It really is. Okay, let's move to part F, exam integration. I want to really nail the comparison tables and Viva traps.
Oh, good idea. Okay, hypo versus hyperglycemia. Summarize the core injury mechanism for each in one sentence for the exam.
Hypoglycemia. Acute neuronal necrosis due to total energy failure. The pump stops, the cell dies. It's a fast death.
And hyperglycemia.
Hyperglycemia. It's the exacerbation of an existing ischemic injury due to intracellular lactic acidosis. The cell cooks in acid. It's more of a quality of life injury.
That's a good way to put it. A good summary might be, hypo kills the patient's brain cells directly, hyper kills the brain's ability to recover from an insult.
I like that. Okay, Viva Trap number 1. The examiner leans forward and asks, "So, doctor, should we just give glucose to all kids to be safe?" The answer is no,
Yeah.
absolutely not. You only give it to those at risk. The preemies, the IDMs, neonates, maybe kids under 10 kilograms. For healthy older children, isotonic crystalloids like plasmolite or RL are preferred to avoid iatrogenic hyperglycemia.
Perfect. Viva Trap 2, you have intraoperative hypoglycemia, you've given your bolus. What next? What's the mistake people make?
The mistake is just cranking up the infusion rate of the maintenance fluid and walking away.
So what's the correct answer?
The correct answer is give a measured bolus 2 LOQ of D10, then recheck the blood sugar in 15 to 20 minutes to see the effect before you make major changes to the infusion. You have to close the loop.
Close the loop. I like that. Viva Trap 3. Tell me about drug interactions in jaundiced babies.
Avoid drugs that are highly protein-bound and can displace bilirubin. The classics are sulfonamides and ceftriaxone, and be cautious with high doses of furosemide.
Excellent. And finally, for the written paper, visuals can help. If you have to draw a quick diagram to explain a concept, what would you draw?
For hypoglycemia, I'd draw the glucose curve, showing the steep drop in the first 2 hours of life, and I'd draw a second, even steeper curve for an IDM baby to show the difference.
Good. And for Kernicterus?
For Kernicterus, I'd draw a simple cross-section of the brain and just shade in the basal ganglia, maybe the hippocampus, to show where the damage occurs.
Simple, effective, gets the point across. And remember, always structure your long answers. Start with the definition, the normal values, then pathophysiology, and then finally, management. Structure will save you when you're nervous and your mind goes blank.
This has been incredibly helpful. I honestly feel like I have a solid framework now, not just a list of facts.
That's the goal. Neonates are metabolic tightrope walkers. Your job is to hold the safety net. And remember, if you don't know a specific value in the exam, err on the side of caution. Your final answer should always be what is safest for the patient. And monitor, monitor, monitor.
Before we sign off, any final piece of advice, the last thing I should do before the exam?
Yes. Go back to your copy of Gregory or drug doses and memorize that normal lab values table for neonates and infants. The examiners know those numbers by heart. You should too. It shows you're prepared.
Will do. Thank you so much, Professor. This was invaluable. And to our listeners, good luck with the prep. You've got this.
Just keep reading and stay curious. The management of these things has changed so much, even in my career. Think about what we've learned about hyperglycemia.
Yeah.
Makes you wonder what we're doing today that will be considered wrong in 10 years.
That's a great thought to end on. Always questioning.